Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by Novartis, Allergan, Janssen, Biogen, AGTC, MeiraGTx, and the SickKids Foundation. We'd also like to thank Accessible Media Inc., our national accessibility partner. Everyone should download the AMI app, which is a fabulous resource, and you can watch excellent programming, including previous Fighting Blindness Canada events. Thank you for watching. We hope you enjoyed this webinar and share your thoughts with us in the comment section below. I'm going to introduce now to you Dr. Laura Swaminis, who's our FBC's Director of Research and Mission Programs. And her and myself are going to relay your questions to Dr. Yoganathan. Laura, over to you.
Thanks, Morgan, and welcome everybody. It gives me a really great pleasure to introduce you to Dr. Deepa Yoganathan. She is an assistant professor in the Department of Ophthalmology and Vision Sciences at the University of Toronto, and she is also the co-president of the Toronto Ophthalmological Society. Since 2010, interestingly, Dr. Yoganathan has been practicing cross-border, so both in the United States and in Canada, and her appointments have included being the director of the retina department at the University of Buffalo, assistant professor at Drexel University and Temple University. She has also initiated her own multi-center clinical trial protocols, and her research interests, which I'm sure she'll be happy to talk about, include retinal trauma, diabetic retinopathy and macular edema, genetics and macular degeneration, and patient-related outcomes. And her passion for excellence in clinical care does include education and patient advocacy. And I think this leads also into how I know Dr. Yoganathan is because we are very, very fortunate that she also serves as a volunteer member on Fighting Blindness Canada's board of directors. And so we work really closely with her to develop education materials for our community as well. So thank you for being here, Dr. Yoganathan. And I'm sure we have a lot of questions for you. So I'm just gonna jump right into it so we don't waste any time. So the first one, sort of, I think an easy question for you is, what is the difference between wet and dry AMD, to really set up this session?
Yeah, thank you for the introduction. And I just wanted to add something to your introduction since that was last written. I did move to Michigan, but I practice in Windsor, Ontario. So I still do, I'm still involved with teaching and research through the University of Toronto, but I closed my practices in Toronto and I opened up a practice in Windsor. So we have a very full, amazingly interesting practice in Windsor and Ontario. And I also work at the Kresge Eye Institute in Detroit, Michigan. So I continue to work cross-border 10 years later.
Yeah, and that must be really interesting with COVID actually going back and forth right now as well.
Yes, there was a lot of drama for just about a month, but now we're back on track where I'm crossing, I cross about 3 times a week.
Okay.
To do half clinic and OR, and then other half clinic and other OR. So,
okay.
So yeah, so to answer your first question, it's a great question. It's a very common question. What is the difference between wet macular degeneration and dry macular degeneration? So the dry is the most common form. A lot of people have a dry macular degeneration over the age of 75. About 20% of patients actually have dry macular degeneration. So it's a very common thing. Hopefully for most people, it just stays without any symptoms. You would never know you have dry macular degeneration depending on the type. So there are 2 types of dry. There's the type that just have the protein deposits in the retina called Druzen, and those don't have any symptoms, may not have any symptoms whatsoever. Other patients who have dry could have something called geographic atrophy. And I don't know if you know what atrophy means, but it is basically the thinning of the retina, and part of the retina just doesn't work anymore. So the most common symptoms of that would be For example, if a patient is trying to read or they're trying to look at something and then there's like a gap in the center, or they feel like they're skipping words. So that would be a sign that you have geographic atrophy as part of your dry. So 10% of patients with dry macular degeneration develop the wet kind. Wet means there's fluid, right? Wet means there's fluid or blood. So there's some leaking. So why do you have leaking? Well, you have an abnormal blood vessel that's growing under your retina that breaks and bleeds. And then a patient may notice distortion. So if you're looking at straight lines, you see the owl behind me, the straight lines. If you're looking at the straight lines, I oftentimes ask a patient to look at a door frame with each eye covered and see if you have distortion. So if you have new distortion, you need to tell your doctor right away, because it could mean that you have fluid in the retina that's causing the distortion, and that would require treatment. Currently, there is no great treatment for dry macular degeneration other than vitamins and screening yourself with an Answered grid. There are great treatments for wet macular degeneration, including injections of Eylea and Lucentis, available to those in Ontario, and in the rest of the country, you may have Eylea, Lucentis, and Avastin available for you for the treatment of wet macular degeneration. And those drugs are 90%. Oh, and also Biogen, that's the new drug that's been released. And those drugs are 90% effective. So we have great drugs for wet macular degeneration.
Can I just have a quick follow-up to that last point you said, because that was actually a startling number to me, 90% effective. So what does that it mean? So does it mean like 9 out of 10 patients who come in will get their, the bleeding will stop? Will their vision improve, or will it stay the same?
So the clinical trial's definition of effective is quite generous if you were to ask a patient or a doctor. So 30% of patients have significant vision improvement. So they have like a few lines of vision gain, like something that would be really remarkable that you would think. The rest of the patients of that 90% stabilize. So they consider stabilization of vision as effective. The rest of the patients would have a decline in vision despite having injections every month. And the reason why someone may have declining vision is because their scarring is just overwhelming. Like when you have blood under your retina, it will scar. And so that amount of scarring may be too much, and you may lose vision, or a patient's geographic atrophy may worsen and may take over the center part of your vision. A common misconception is that when you develop wet macular degeneration, that you no longer have dry, but the dry actually continues to advance. So when you have a patient with dry macular degeneration that develops the wet, they now have two diseases that could be managed. So their dry macular degeneration will keep on doing whatever it wants to do, and we can only treat the wet kind.
So we had a question from Kamal, and he said, if due to a history of retinal detachment and the surgical procedures, AMD has set in and has been getting progressively worse with a visual acuity of 20/400, what is currently the best treatment available?
So there's no relationship between retinal detachment and macular degeneration. If a patient develops macular degeneration, they probably would have already developed it. So I would just treat it the same way that you would treat any macular degeneration. So if it's dry, vitamins, depending on the type of dry, vitamins are only good for the stage 3 intermediate dry macular degeneration. And if it's wet, then any of the 4 drugs available for injections.
It actually leads pretty well to the other question. The next question we received was, I was told I need injections. I know there are several different medications. What are the differences, and how does my doctor decide which one I should use? And then there was a sort of follow-up questions about how often will I need to have injections, and maybe if you can describe how it's determined, how often somebody might need to have injections, and what drug they might be chosen.
Sure. So the most common drug used in the world and in the United States is Avastin. Avastin was never made to be injected into the eye. It's a cancer drug that is injected intravenously. But if you take 1/20th of a vial of Avastin, it is very similar, I would say, to the approved drugs for macular degeneration. And therefore, because the cost is so much less, it's $100 or $200, let's say, as opposed to $2,000. That's why it's the most commonly used drug in the world, including the United States. So, depending on your provincial coverage, your province may dictate what drug you get. In Ontario, fortunately, our province does not dictate that we have to inject with Avastin first, so we get to decide which drug is best for our patients. So out of the approved drugs, there's Lucentis, Eylea, and Beovu, which is the newest drug. Lucentis has been around the longest, since 2005 in the US, 2006 actually. And the same company, Novartis, makes Beovu as well, which is their newest drug, which was just launched in Canada in May. So the doctors are just learning how to use it, and just getting into it. So that may take some time for it to be more available. And the Bayer makes Eylea, which is a wonderful drug. It does very well to dry up the retina and dry up the blood and fluid. So there's 3 different drugs that work very well. Most of the time, the differences in terms of clinical trials are small, like within a few letters difference. So even though the drugs like Beovu and Eylea are better to dry up fluid, which is what we originally thought we wanted, some professionals say that maybe we don't want to dry up the retina too much. Maybe we want it only a little bit dry. So you can see that a lot of this is sort of artistic in a way, that it's up to the individual doctor's experience and preference. Since all the drugs work so well, I think just a conversation with the patient as to how things are going with one drug and whether there actually needs to be a switch. Sometimes if we are trying a patient and we are injecting them every month, and they just have too much fluid, we may switch drugs to see if maybe they are personally more responsive to a different drug. Every patient is an individual, and their own sort of hormones in their eye may be more responsive to one drug or another, and you don't really know until you try. So sometimes doctors switch, or sometimes doctors feel like just staying on course and injecting every 4 weeks is the best way. There are studies, for example, in Canada, we had the CAN-TREAT study that showed that if you do something called treat and extend, it is equivalent to injecting monthly. The way the drugs were approved, or they were approved for monthly dosing, so every 4-week dosing for 2 years at least. So CAN-TREAT showed that you can inject based on an individual's response. So every time a patient comes in, we do an OCT scan that looks at the fluid in the retina, and we decide, is the fluid better? Great, let's keep going on a lighter schedule. If the fluid comes back, then we have to go on a more aggressive schedule. So medicine is personalized, like it is in oncology and other fields. The retina treatment is personalized just like it is in other fields in medicine. So again, it's about how the patient is responding based on the drug that we're giving them.
Absolutely. So we've had a lot of questions about vitamins and nutrition. So I wondered if you could comment on sort of what sort of supplements are available for AMD, and what sort of connection does nutrition and the gut and the eye have? What are they all, how do they work together?
So it's a great question. Patients oftentimes ask, is there anything they can do to help their eyes? So a general answer is to eat healthy, exercise, decrease your sun exposure, wear a wide brim hat, wear sunglasses. That's typically if you're a lighter skin, fair skin, more Caucasian, blue-eyed patients. The more darkly pigmented patients are not as high risk. In terms of vitamins, I generally recommend a multivitamin. With regards, there were a couple of questions about vitamins for macular degeneration and genetic testing. So I'll just launch into all of that now in anticipation of your future questions. So this has been a highly controversial topic since 2013. In 2013, there was some data, really interesting data, published by a retina specialist in Nashville, Tennessee, and co-authored by the company AGTC, that is based in Mississauga, actually. And so they found out that depending on your genotype, that the vitamins that you take may make you advance to macular degeneration worse, so that they may be exposed to the zinc or the multivitamins that are advertised for macular degeneration, and that they may progress quicker to worse wet macular degeneration. So this has been highly controversial, as you can imagine. The statement for the standard of care by the American Academy of Ophthalmology is to not do genetic testing. They have been very clear. Every time they've been challenged, they've been very clear. Do not do genetic testing. However, again, the physician may feel differently. So based on my own research that I performed in Pennsylvania, I personally feel that there is some indication for genetic testing depending on the very specific type of macular degeneration that you have, which would have to be diagnosed by a retina specialist, and therefore, or an ophthalmologist or optometrist that is educated about that specific type of macular degeneration. But I think that there is a place for it, just not for every single patient, because it's not helpful for every single patient. Eating green leafy vegetables, orange vegetables, making sure you have fish, making sure you have a well-rounded diet, all of the healthy things that you would normally prescribe to yourself, you would do that for macular degeneration as well.
You answered the question I was going to ask. I might just have another little follow-up about, you mentioned about eating leafy greens, wearing sort of doing sun protection. Are there other risk factors that either lead some people to be more prone to get macular degeneration or to progress to wet AMD?
So 100% smoking. Smoking is the first question that anybody with macular degeneration needs to be asked. Unfortunately, by the time patients get macular degeneration, they've been smoking for 40 years or so. Obviously, it's hard to quit smoking. It's hard to think about changing something that you've been doing for so many years. But macular degeneration is a combination of genetics and environment, and therefore, the reason why smoking advances macular degeneration, because it's a toxin, and the outer layer of the retina, the RPE, the job of that layer of the retina is to remove toxins. So if it is overwhelmed, and that's why the vitamins are antioxidants, right? Because you're trying to remove the toxins from your body. So if that layer of the retina is overwhelmed and just is trying to fight and remove toxins and remove toxins and remove toxins, it's going to get tired and it's going to stop working. And that's what happens with macular degeneration. Obviously, you have a genetic predisposition to getting it already, but the combination of the genetics and the environment is what leads to the diagnosis.
And then the last follow-up question, I'm sorry, Morgan, was about the genetics. So is there, based on your research and what you've read, so is it more, like, is it a specific gene? So say in inherited retinal diseases is often like one gene and one mutation predisposes you. Is it the same with AMD where you know that there's a handful of really important genes, or is there a lot of different things at play?
There are quite a few genes, but interestingly, all at the same time, there were 4 different labs in the United States that discovered that complement factor H, a mutation in complement factor H, was one of the most contributing genetic abnormalities to AMD. And the other one that is that contributes is ARMS2. So a CFH, complement factor H, and ARMS2 are the 2 that make up the commercially available genotyping that allows us to put you into a certain category that makes you at high risk exposure to the zinc, or low risk, meaning the zinc benefits you or the zinc harms you. And there's some theoretical story to that those genes use zinc to process, the little microenvironments of proteins, and therefore the processing or the lack of processing of the zinc is what leads to the harm with that genetic mutation. So there's definitely a few different factors, but some more important. CFH is the most important.
Okay, so we have another question here. Read this one. So there are many studies that show the benefit of red light therapy and transcorneal electrical stimulation to improve vision in AMD. Do you recommend any of these devices? And what would your advice be about these particular the usage of these devices?
I'm not familiar, and actually we have never spoken about that at a retina conference. So if you want to send me a reference, I'm happy to look it over, but it's not something that is typically just, discussed or promoted.
So this is also about, I think, innovative treatments. We have a lot of questions about sort of innovative treatments for AMD, so specifically stem cell therapy or gene therapy. So do you know if there's any advancements that are either in clinical trials that might be beneficial for individuals who have AMD? And if so, do you have an idea of what the timeline is for them to be available?
Yes, that is a very exciting question. There's definitely stem cell therapy that is on the horizon. Actually, I was vying to be a clinical trial site in Windsor. And we were we were getting pretty close to that stage, but the trial involved putting patients on immunosuppressives. And because of COVID, the trial designers realized that no one is going to agree to be on immunosuppressive drugs, and therefore they have to redesign the trial and start over. So this is going to delay us probably by 2 years, at least 1 year. So I'm hoping in either the end of 2021 or 2022, we can think about clinical trial sites throughout Canada, and that is specifically for the diagnosis of geographic atrophy.
So this is another question. I've had dry AMD for years. I'm 74 years old. Said it hasn't been too bad, just had decreased light sensitivity. About a year ago, I also developed wet AMD. I lost the ability to read in my left eye, and then my right eye also was affected, and I lost my driver's license and was barely able to read in only 2 weeks. The question is, what might be the long-term scenario for my vision? They say, I'm still having injections in my right eye, but the left one seems stable and is not being treated right now.
Yeah, this is devastating. I mean, to lose your license and to lose your independence is awful. And I feel so bad for my patients who have had very similar stories. So the way I explain the injections to the patient is that what we inject and them showing up, how often we inject and for the patient to show up to their appointment is the only thing we can control. We cannot control how their retina is going to respond to their drug. We cannot control how much their fluid goes away or how much their blood scars. We just have to take it day by day and see how the drugs work and just really hope that they get the best outcome possible. But there's no magic to these injections other than the injections themselves. These drugs are miracle drugs. Imagine what happened before 2003 or so where there was no treatment. So this has revolutionized the field of retina. There is actually a field of medical retina now because of that. But in terms of knowing what the future holds or whether there's any hope for the eye, obviously it's a very individualized situation, and I would encourage patients to discuss with their doctor, do you really think my vision is going to come back, or is there still hope? 30% of the patients gain their most amount of vision in the first 3 injections, but there is another 30% of patients who gain it later. So later in the year, or even at the beginning of their second year of treatment. So if it's still within the first couple of years of treatment, I would encourage people to be hopeful. If there's a reason, like if there's some, if there is good response. Obviously, if it's been many, many years and there's no change, that's a different story. But there are what we call late responders in this disease.
Thanks. So I've got a question here from Katie, who says, in the midst of COVID-19, I was sent to an ophthalmologist to determine what was wrong with my eyesight. I was diagnosed with dry macular degeneration or Stargardt's disease. I'm 38 and I'm waiting to see a retina specialist. Are there ways to deal with the anxiety of waiting for a specialist?
Well, I guess it depends where Katie lives. There's plenty of retina specialists in larger cities. So if Katie is willing to travel to see a retina specialist who'd be willing to see her, I think that would help relieve the anxiety. Obviously, it is anxiety provoking. Most of my patients, actually, when I see them, I don't even have a long wait list. I try to see patients within a month or so. And when they see me and I finish their exam and I tell them, oh, everything's fine, they're like, oh, what a relief, and I feel so bad that they are filled with this anxiety. And I guess the question is, what is making them anxious specifically? So is there going to be news? Is the retina specialist going to give them news that would change their life? Unlikely, right? So if you have a condition, but you're managing fine and you're doing your activities of daily living just fine and everything is going about just fine, then it's unlikely that the retina specialist is going to tell you you're going to go blind next year. That is a very rare and unlikely scenario. If you've already lost vision, it's also unlikely that the retina specialist is going to say, oh, I have something that is going to save your vision. Do you see what I mean? So I think, and if that were the case, if it were the case that the retina specialist has something that would save the vision, they would be seen in a shorter amount of time, right? And like patients who develop wet macular degeneration typically would get seen within a couple of weeks. Because you want to inject as soon as possible. Anyone who needs an urgent surgery would get seen within a couple of weeks. Anything that is not going to change their outcome, that's when the referral may take a couple of months, because there's nothing that the retina specialist is going to do to necessarily change their course. So I think perhaps focusing on what the outcome, how the outcome may not change, may be a way to deal with the anxiety. But I think if you just ask the referring doctor, is there another retina specialist that you can send me to that has a shorter wait list? I think that would solve the anxiety a lot quicker if you're willing to travel. And I have, because I'm in Windsor, that's pretty far for most people. Otherwise, I would say, yeah, I'm sure, I'm happy to see you next week. Like, no big deal, But I can't say that. I don't know where she lives. I don't know what retina specialists there are in that area, so I can't comment on their availability.
So I have a little bit of a follow-up. So with the COVID now, have you seen a situation where some people are either afraid to come in or are missing treatments, or has your clinic been able to sort of manage that process? Because that must have been pretty stressful at the beginning.
Yeah, so we did actually study our own results. We were shut down for 2 months, except for true emergencies, like patients who really, really needed their injections. I have a new practice, so therefore most of my patients were doing pretty well, actually. I don't have those patients who've been in, I have very few patients who've been injected for 6 years or whatever, like I did in Toronto, where I was there for 9 years and had patients that needed injections for years and years and years. So I only had maybe less than 10 patients who needed to come in during those 2 months, and my partner injected them for me. And then when we reopened in May, we just brought everybody back, obviously social distancing. And, a lot of patients, their fluid did come back. But we studied that after just one injection, most of them went back to baseline. So most of them went back to how they looked like before COVID, meaning doing pretty well, which again, just is a testament to how amazing these drugs are, these injection drugs. There was, I think, 90 something percent that went back to baseline after just one injection. And then a few percent, the rest of them actually just needed 2 injections and they went back to their baseline. So pretty great recovery after missing those 2 to 3 months of injections. So what are the issues that COVID presents? Well, the whole administration and scheduling is very challenging to just keep up with all these patients, to make sure we're not missing patients. Patients sometimes feel that they're bothering us by calling, and they assume, when it's time for their next appointment that we will call them. But, it's just very difficult to keep track of all the patients. It's very difficult. I have gone through our scheduling system with my staff. I have a big staff. I have 3 full-time staff and 3 part-time staff for just me, and I only work in Canada a day and a half a week. So that's a lot of people just to manage a day of clinic a week. That's a lot of people that you need. And managing the injections takes a lot of work, managing the patients to figure out how to get them in every month. So there are patients who call and say, hey, I haven't been rescheduled, I haven't been rescheduled, when's my appointment? And we're like, oh yeah, definitely come in. So I would any patient who feels that they should have been rescheduled, please call your doctor and have them check whether you need to come in or not, if you feel that, maybe you were kind of dropped between the cracks, as we say. So other than that, we have had to hire 3 more people for my clinic days to do all the cleaning. So now in my clinic, we have 9 staff to manage just me. There's no other, we only have 1 doctor working at a time. So I'm the only doctor and I have 9 people. So we have 1 person at the door checking temperatures, another person cleaning the front area, another person cleaning the back area, and then all my staff to take their Optos images, OCT images, check their vision, pressure, and then to put them in one of my 3 lanes that I use to see patients. So it's a lot more people that we need to manage, to keep people separated, to try to limit exposure. Everybody wears masks. We limit the number of people in the clinic. We ask people to wait in their cars if they're too early, that sort of thing. So, but we are back on track in terms of getting our patients injected. I am able to inject them every month if they need injections every month. So we are back on track. It's just a lot of, it's just hard to keep track of all the patients. There's no foolproof system. I'm part of many physician sort of groups, like whether it's Facebook groups or collegial groups, and these are issues we talk about all the time. All physicians have difficulty keeping track of their patients, communicating with their patients, scheduling surgeries, scheduling appointments. It's a common problem for all physicians to figure out how to deal with the administration of healthcare. So we're always trying to improve. I'm always trying to reduce my wait times. I'm always trying to make sure we give quality service, but not make patients wait. I mean, I'm constantly trying to improve the service in our clinic, my practice. It's just always a work in progress, as I tell my staff, because every week I'll have a new idea. Oh, let's try this and let's try that. And then they feel that I'm criticizing what they did. And I'm like, no, you did that great, but let's just try something new. We're always talking about efficiency and trying to make things better for the patient.
That's it's really interesting to hear about that, and I think a great sort of message for patients about, if you haven't heard from your doctor in a while, reach out to them just to make sure that take sort of your appointments.
Yeah.
I'll turn you back to Morgan.
Okay, so we have a question in the Q&A here from Sanita, and she's asking, if one eye is affected, will the other be automatically affected?
No, definitely not. So typically, if you have dry macular degeneration, both eyes are affected, but most of those patients don't have any symptoms. But if you have wet macular degeneration, there's about a 40% chance that you will get it in the other eye. So it's not a guarantee.
I'm also going to go to, we've got 2 questions about actually vitamins. I'll put them both together from Susan. Both my parents have had dry and wet AMD. Would I benefit from taking a vitamin supplement such as Vitalux as a preventative? And Jean asked, so are the AMD vitamins safe? Is it just zinc that is an issue, or are there other things that people should be aware of?
So it's not just zinc, there's vitamin E. And actually, if you look at the vitamin contents, ingredients, most of them are all above threshold, daily recommended thresholds. So you should definitely not be taking Vitalux or an AREDS formula vitamin unless your specialist tells you you have X type of dry macular degeneration. And the AREDS study shows that you would benefit from this type of vitamin by reducing your progression to wet macular degeneration by 25%. It is a very specific recommendation. So in general, I would just, if you want to take a multivitamin or again, enhance your diet with all the good stuff, that would be a better recommendation than to take the other things. And are the side effects common? No, but there are plenty of reports about these high doses of vitamins that can cause urinary tract or GI tract issues.
Okay, and now in the chat Q&A as well, Ginny asks, how likely would having glaucoma lead to having AMD?
I don't think there's any correlation between glaucoma and macular degeneration, other than generally the risk with age increases. And then I saw another comment in the chat about diabetic retinopathy. Again, diabetic retinopathy would not lead to macular degeneration. They could lead to its own degeneration, like its own, the cells that it has affected don't work anymore, but that wouldn't be considered age-related macular degeneration like what we're talking about.
For sure. And I will just do a little plug to say that we are doing a session on glaucoma in October, and November is Diabetes Month, and we'll be doing a bunch of webinars on diabetes and diabetic eye disease. So if you're affected by those conditions, I definitely encourage you to come back and ask your questions about those specifics at that point. Since I'm already talking, I'm going to just do another one here. So Brian said, I'm 72 years old and I've just been diagnosed with wet AMD. I will be starting injections this week. My question is, does wet AMD progress faster the older you are?
Interesting question. I've never thought of that. Does it progress faster? No, I don't think so. I don't think there's been any evidence that shows that older patients do worse to treatment. And whenever you do a clinical trial, when a company designs a clinical trial, they want to ensure the most favorable results in that trial, as you can imagine, right? If you're investing millions and close to billions of dollars, you need to make sure your results are good. So what do? They make sure that the vision maximum to enter the trial is not so bad. So patients who see count fingers are not allowed to enter the trials. So you have to see like 2300 or better, for example. If patients have a lot of blood in their retina, they're not allowed to enter the trials. So they already sort of curate and, narrow the people who are eligible for the trial so that they have the best outcome. And age has never been limited in trials. I think they go up to 99. I think that's maybe there's a max age for other reasons, but they don't say, oh, we're only looking for patients between 65 and 75. So I think that alone tells us that older age patients do not necessarily do worse.
We have a question from Leslie. So she talks a little bit about her own personal eye history, which is in her left eye, she has high genes myopia, dry macular degeneration, and stable wet macular degeneration. And in the right eye, dry with geographic atrophy. And then it comes to, I think, a question that a lot of people have about the geographic atrophy in the late stages. So would she be potentially past any gene or stem cell therapy? So I think we get that question a lot about if my vision loss has progressed a lot, am I still eligible for some of these new treatments that might be coming?
Yes, I think for sure that's what I'm hoping for the Astellas clinical trial. If in the next couple of years it does end up coming to Canada, I think these patients would definitely be eligible. I have been able to read the protocol, so I think it is. I think there are definitely going to be options for a lot of our patients that all of this time we've just had to say, I'm sorry, there's nothing we can do. Obviously, it's up to the investigators who are designing the trial to make the decision for that.
Great. So I have a couple questions here, one from email and one in the Q&A about cataracts and AMD. So I'll just read you, this is from Dorothy, and she said when she was 94, she went to her eye specialist, and she said that she had a film starting to grow after her cataract operation and that it should be removed. So she had like a laser therapy to remove that. And then shortly after, she was diagnosed with macular degeneration and is now doing injections. She's just saying it's very hard to go through this. She's 95. And she's wondering if the laser treatment was responsible for the macular degeneration, as no one in her family is affected. And someone in the Q&A has also just asked the same sort of question, is that can removing cataracts affect AMD?
So again, a controversial topic. There have been some studies that say that removing your cataract does advance macular degeneration, but an analysis of all the studies has shown that there is no advancement of macular degeneration after cataract surgery. So, there's a lot of people who've studied this. There's a lot of people who've asked this question. Um, so probably the answer is, if you're going to get macular degeneration, you were going to get it anyways. There's nothing that actually happens in cataract surgery that you would think would lead to the development of macular degeneration. You know what I mean? The cataract is in the front of the eye, the retina is in the back of the eye. There is more light that enters the eye after cataract surgery, but there's been years and years. Macular degeneration is a process of years. It's not a process of 6 months. So again, a controversial question with no extreme 100% conclusive answer, but a lot of the data has questioned it, and most likely there is no advancement of macular degeneration after cataract surgery.
Okay, I think I'll ask one last question from the things, and I'll turn it back to Morgan to decide if we've got time for any more. So the question from Ali is, what are the very early symptoms of dry AMD? I know you talked about it a little bit at the beginning. So just building on that, what would you tell people to do in order to make sure that they are checking their eyes regularly? At what age should we be going for more regular checkups? And if it's in my family, whether it's glaucoma, cataracts, or AMD, am I more likely to get it myself? So does that make me more likely?
I think an annual checkup as you get older is a good idea. I know typically when you're younger, people go for an optometry visit every 2 years to check for glasses and things like that. So if you're concerned about a family history, I think going every year would probably help with that. There are no symptoms of early dry macular degeneration unless you have geographic atrophy. Druzen don't cause any symptoms. The best way to test if you do have dry macular degeneration and you're worried about it turning into wet is to do a weekly Amsler grid. So you can Google what an Amsler grid is. It's basically a piece of graph paper. If you have a piece of graph paper at home, there's nothing fancy about it. Draw a circle in the center of the graph paper, cover one eye, focus on the circle, see if the lines around it are straight, the horizontal and vertical lines. Cover the other eye, do the same. Put this piece of graph paper somewhere where you'll see it often. Put it on your fridge door, put it in your bathroom mirror, somewhere that it doesn't take a lot of effort for you to do. Stand at the same distance away every single week and do it once a week, where you check the vision in each eye to look for any new distortion. Distortion means that the lines are wavy. If you already have distortion and your doctor's already looked at you and you don't have wet macular degeneration, then that's your baseline. So from your baseline, you're looking for worse distortion.
And I have another question here in the email also about dry. So we've already kind of mentioned, like, right now there's not really any treatments for dry, but Sylvia's asking, is there any research that gives hope in the future to treat dry macular degeneration?
Yes, the Geographic Atrophy trials are hopefully coming in a year or two as a clinical trial, and then obviously to market would be a few years after that. But yes, definitely hope.
Okay, I have another one in the email from Milton. And Milton's asking, can people with complete loss of central vision benefit from electronic goggles such as eSight, Zoomax, or the Geordie? And is there a minimum limit of acuity that's needed to really benefit from these type of technology?
I would encourage this patient to see a low vision specialist who has more access to these devices. So there are many devices for people who do have you know, basically the loss of the center of the vision from macular degeneration. I'm not an expert at that. In Toronto, there are, I think, 3 low vision specialists who may be able to advise better. But there are definitely people. I know I had patients that use the devices, and they say it's pretty interesting. It's pretty helpful. It's not like, oh, you know, you were blind and now you can see type of thing. But for the right patient, I think it can work. I have had patients who've tried it that have not worked either. So again, in a very individualized situation, no one could make a blanket statement about any of these. Otherwise, everybody would have them.
Yeah, I mean, I can reiterate that to everyone that I've talked to. You know, it's just so important to go and try the technology before you consider it, because it may or may not work for you. And just going back to actually something you said before, we do have Amsler grids at Fighting Blindness Canada. So if anyone out there would like an Amsler grid, we can mail them to you. If you email me at education@fightingblindness.ca, I will make sure to get you one. Okay, so we're running out of time, but we have a couple more questions here in the Q&A. I think we can tackle. So Anne is asking, I have dry eyes, narrow angles, and I've had I don't know how to say that word, anyone help me out? Iridotomy? Stage 60 in the Q&A. What should I expect as I age? My 96-year-old mother is legally blind with glaucoma and macular degeneration. Sorry, I butchered that word.
Yeah, so there's a lot of words in this question. I have dry eyes. I think that's a separate diagnosis of narrow angles that require an iridotomy. I'm not sure what stage 60 refers to, but when you have narrow angles, it means that the fluid in the front of the eye is getting trapped, and therefore the iridotomy is like a release valve. You laser a hole in your iris to allow the fluid to come out. So that's more of a glaucoma or anterior segment specialist type of question. Dry eyes could be related to a dry cornea, which is very different from dry macular degeneration. Oftentimes, people may use the term dry, but we don't know if they mean a dry cornea or dry retina. Dry macular degeneration, sorry, not dry retina. So for dry corneas, for dry eyes, there are many things you can do. Artificial tears 4 times a day, warm compresses with circular lid massage, flaxseed oil, omega-3 supplements. Those are all things that can help with dry eyes.
Great, and I think just one more question here. Can you have both geographic atrophy and Druzen at the same time?
Absolutely. Oh yeah. The majority have both at the same time.
So I think that's all for our questions.
I just wanted to, I saw that last question about the tiny black spots.
Oh yeah, sorry.
I didn't want that patient to not get their question answered, but also I would encourage that patient to see their eye doctor, because tiny black spots could be many, many, many things. And so you would need an eye exam to correlate what that could be from. And we wouldn't want to be diagnosing online without the proper information and a proper examination.
Absolutely. Sorry, yeah, that one got lost on me there. So thank you so much. Did you have any final words of advice for anyone who's sort of experiencing these issues right now with either type of macular degeneration?
Yes, I would say please talk to your doctor if you have anxiety questions. You know, if you have questions about the treatment, if you have questions about prognosis, I feel that, you know, patients oftentimes feel that they're bothering their doctor because things happen so fast and we have so many patients to see. I think it's okay to occasionally schedule a consultation appointment if you feel that, you know, there's just so many questions that you have unanswered. In general, though, as I mentioned at the beginning, there's no magic. No one has a secret answer for how to manage macular degeneration. We talk about this all the time at every single conference. Oh, is it better to inject monthly? Is it better to inject treat and extend? Is it better to wait for the fluid to come back? Doctor, why are you injecting me when I'm already dry? You know, there's the initial stage, and then you have a maintenance stage. And so we continue to discuss it. We will always be discussing it, it seems like, which drug is better, et cetera, et cetera. And so if there was a clear answer, everyone would be on the same thing and the same regimen, and there's not. So it is basically a balancing act between the needs of the patient and the drugs available. Obviously, your doctor is going to try their hardest to treat you with the best possible options. And if you have any questions about that specifically, you know, I would encourage you to ask your specialist.
Well, that's great. Thank you so much, Dr. Yoganathan. I keep saying it wrong. You know, it's so funny because, you know, we've been doing these webinars and everyone just wants more time for Q&A. So this has been really wonderful to be able to get everyone's questions answered today.
Yeah, I didn't know that you could do an entire hour of just questions.
We've had this before, and we've, you know, the speakers speak and then we're just so rushed in the last 15 minutes. So it's so nice to just slow down and be able to get everyone's questions out there. I did just want to repeat the email address for any of your questions about Viewpoint, or if you'd like one of these Amsler grids mailed to you, you can reach me at education@fightingblindness.ca, and we've put that also in the chat window there. I will send everyone a follow-up email as well, so you can always just reply to that when you get it. So if you enjoyed today's webinar, I do encourage you to visit our virtual events page as well. Our next webinar, as I mentioned, is all about glaucoma. It's our first glaucoma webinar, so that's very exciting. And it's going to be on Tuesday, October 6th at 4 o'clock. We also have a bunch of other webinars announced that are on our website. We have, if you're interested in specifically the link between the gut and the retina, we have a great webinar about that in October. And then Diabetes Month is November, so we will be focusing on diabetes and diabetes-related eye disease as well. I do encourage you to fill out the survey that pops up after the webinar just to give us an idea of what you liked about the webinar today and anything you think we could improve upon. We're always reading your feedback and improving on our webinars based on that. And I will send you this follow-up email with a link to the video. So if you have friends, family who couldn't make it and you're interested in them watching it, please feel free to share that with them. And just lastly, before we close, I really want to thank our monthly donors who've tuned in today. We can't do what we do without your generous support. So thank you so much. You know, bringing these innovative sight-saving treatments to Canada is what we do. Research is very expensive, but it is also life-changing. So anyone who's interested in joining our community of core supporters, you can make a huge difference by joining our monthly giving program. For as little as $1 a day or even $10 a month, your gift can make a big impact for people living with vision loss. And we really talk about monthly giving because it has a couple of really good benefits for us and for you, in that it provides us with a reliable and consistent source of funding that ensures that we can direct our long-term investments into vision research. And it also reduces our administrative costs, so more of your money can be directed directly to the research that we fund. So if you're interested, you can visit us at fightingblindness.ca, or you can always call us at 1-800-461-3331. Thanks again for Dr. Yoganathan and everyone here for joining us today. I hope you stay safe and healthy, and we will connect again soon. Take care, everyone.
Thank you. Have a